Yeah, good evening, everyone. Good evening, Pranay sir.
Good evening.
Yeah, first of all, I'd like to thank ECMO Society of India for giving me this opportunity. So, the next few minutes, I'm going to talk about sedation analysis in ECMO. Myself, Dr. Rakesh from Hyderabad. I don't have any conflict of interest. I don't have any pros and cons for any drugs and all. So, coming first to the topic, the basic of the topic. So, it was actually defined in the earlier period itself that what all the happiness a human can get. So, it's not the pleasure that is going to be the happiness, it's just the rest from pain. So, if you relieve any human being from pain, that itself is the biggest pleasure anyone is going to get it. So, let us see the learning objectives of this lecture. I'm going to say what guidelines are telling us. Is there any validated scales to measure your pain, sedation, or anything? Something like agitation and delirium, limitation and benefits of various drugs that are available, and when it comes to especially in ECMO, what modifications you're supposed to do, because ECMO patient is not same like as it's not equal to your ICU patient. So your ECMO patient is different. Coming to the sources of pains in the ICU in ECMO, it might be any surgeries, it might be presence of lines, it might be presence of your intercostal chest drains, it might be presence of your catheters, ET tubes, pre-existing conditions, bed sores, nursing care, which we generally do like suctioning, sampling, etc., and then immobilization in bed. So all these are all the sources of pain in ICU. Coming to consequences. So what happens if there's a pain? There will be sleep deprivation, there will be agitation to the patient, there will be much more stress response, which leads to severe autonomic dysfunctions like your tachycardia, hypertensions, or bradycardia. Sometimes it leads to your hypercoagulability also, and then immunosuppression of the patient. Higher catabolic states, muscle splintings do happen if the patient is becomes agitated. Psychological disturbances like delirium, post-traumatic stresses do happen. So to prevent all these things, your patient should be absolutely pain-free. So what are our goals here for sedation analgesia? To decrease the pain and anxiety, to decrease the patient's stress response. In a way, you're decreasing the oxygen consumption as much as possible. And we want the patient to have synchrony with the ventilator by decreasing your pain and anxiety. And I also want to avoid any neurocognitive sequel like post-traumatic stress disorder. I mean, like post ICU dementias, anxieties, and all. And ultimately, the most important thing being increasing the family acceptance of ICU care. So if your patient is always sedated and paralyzed, no family is going to accept that you're doing a very great justice for the patient. So to increase the family acceptance, you need to see the patient conscious and obeying. So how to assess pain first of all? The most reliable is a patient response rather than the self-reporting of different scales. So you should ask the patient if the patient is conscious and all. You should ask the patient about his patient pain. And when it comes to objective measurements, you have verbal rating scales, we have visual analog scale, we have numerical rating scale, and behavioral pain scale. Of all these things, which we commonly follow is the behavioral pain scale, wherein we have three parameters, and then each parameter has a score of 1 to 4. The score ranges from 3 to 12. Okay, 3 being no pain and 12 being the maximum pain. So this is one way of measuring the pain. So, and then why does delirium happens here? So because the patients will be on opioids and benzodiazepines, there will be hypoxia for these kind of patients. Chronically ill IC patients will have metabolic derangement. So all these factors will lead to your imbalance of your serotonin and acetylcholine hormones in your brain and dopamine. So all these hormones imbalance ultimately leads to delirium inside the ICU. So is there any measures to measure the delirium inside the ICU? So we have a tool called as CAM ICU tool, which measures the delirium in the ICU. Wherein a simple 4 steps maneuver, you can identify the patient, whether the patient is in acute delirium or not. The first step being assessing his neurological changes from the last 24 hours. If there is an acute change of mental status, if there is an yes, you should go for the second step. If there is no, there is no delirium. The second step is inattention. So whether he is able to pay attention to your commands. So a simple command like whenever you hear a letter of A, you should press the hand. So if he is able to do or is able to keep attention for your commands, that means there is no delirium. If the errors are more than 2, then you should go for altered level of consciousness, wherein you use Richmond agitation sedation score. If the score is other than 0, that is delirium positive. If the score is 0, then you should think of your disorganized thinking. So there is a mismatch of your thought process. So he will say that stone is able to float in the water, fish can walk on the sand and all. So all these disorganized happens. At this step, if the errors is more than 1, then again the patient is having delirium first. So this is called as CAM ICU tool, wherein you can easily assess your delirium, presence or absence of delirium. So we have a Society of Critical Care Medicine guidelines that says that. So it should be always assessed. The depth and quality of sedation should be always assessed in all ICU patients. You need to have a documentation of your scores, either it might be Richmond score or it might be Riker score. So it should have a documentation. You should also use objective brain function measurements along with sedation scores, along with pain questionnaires and all. You need to have objective brain function measurements like EEG and NCSC for all high risk patients. So try to target the lightest possible sedation, or you can daily use daily sedation interruptions also can be followed. So you need to have sedation protocols and checklists. Try to avoid benzodiazepines for always your sedation. So that's what the guideline says. So the scoring systems, they help to monitor your depth and quality. It should be simple, easy, and then it should be reproducible. You have three scoring systems most commonly available. Richmond agitation sedation score, the target being 0 to -1, that's the target here. And this other one might be your Riker scoring systems. The target should be around 3 to 4. Patient should be calm, cooperative, and sedated. Or it might be Ramsey scoring system. Again, the target is around 1 to 2. Patient should be awake, patient should be cooperating. Okay, that should be the scoring targets. So coming to objective measurements of brain activity, what you can do here is you can measure the objective brain functioning in terms of EEG, or you can use bispectral index or evoked potentials. So bispectral index, index uses multiple parameters like your patient safety index, narco trend, and cerebral safety index. So these are the various indexes which was reproduced by the machines here. You need to connect 4 electrodes to the patient's brain and you need to assess the score. So it automatically calculates the different EEG potentials and it will give us a final score. Let us see. The score ranges from 0 to 100, 0 being isoelectric ECG or EEG or deep anesthesia. The patient is in anesthesia, the target is around 20 to 40. If the patient is in ICU and the patient is especially on ECMO, the target is around 60 to 80. The patient should be in a slightest or moderate sedation. So that's the target of your bispectral index here. EEG. It is generally done for all our neuro ICU patients, and then the patient is having high risk for your non-convulsive status. So by measuring all these things, our target is lightest possible sedation. So how does your daily sedation interruption helps you? It always helps you in allowing the better sedation needs. So once you stop the sedation and assess the patient needs, that will help you to understand how frequently he requires, what are the dosage requirements and all. And also it helps in reducing the drug accumulation in either in the circuit or in the patient's body and reduce the incidence of post-traumatic stress disorder and then reduce the incidence of critical illness. So in a way, it reduces the ventilator-free days. So sedation therapy, I'm not going in detail. It's broadly divided into pharmacological and non-pharmacological. Non-pharmacological things are simple reassurance, communication, and environmental control like humidity, lights, temperatures, and all. Management of thirst and hunger. So every agitated patient is not because of pain. He might be having a full bladder. He might be having a dry oral cavity. So he might be calling you for what do you say, for managing those things. Okay, it might not be the pain always. Okay. Prior explanation of the procedures always helps to gain the patient confidence also. Coming to pharmacological agent. So any ideal agent should have the following properties. It should be both sedative, anxiolytic, and amnestic and anticonvulsant. Minimal side effects, rapid onset and offset. No accumulation, whether there is a hepatic or renal failures, and there should not be any active metabolites. So coming to pharmacokinetic considerations, especially in ECMO, it might be patient's fluid status or volume of distribution of the drugs, serum protein levels, renal and hepatic dysfunctions. So you have different drugs here. You have analgesics, opioids, non-opioids. You have sedatives like benzodiazepines, propofol, and ketamine. We have miscellaneous drugs like haloperidol, quetiapine, atypical antipsychotics. We have alpha-2 agonists, clonidine and dexmedetomidine, and you can also use regional anesthesia techniques. So classification. So when it comes to opioids, the most commonly used opioids being fentanyl, morphine, and hydrocodone here. So yesterday I'm discussing on this slide. So fentanyl is the most commonly used opioid because of its highest degree of lipid solubility, and there are no active metabolites, no chances of histamine release, and there is no requirement of renal dose failure adjustments. But when it comes to morphine, morphine is actually less lipid soluble. So what happens is it also comes with some active metabolites, and there is a histamine release action also will be there with morphine. And then you need to decrease the renal dose adjustments to 50% whenever there is an AKI. So coming to a newer drug called as remifentanil. So it's an ultra short acting drug where you can use a continuous infusion of remifentanil 0.5 to 1.5 micrograms per kg per hour. So analgesic effect stops within 10 minutes of stopping the drug. There is no accumulation of remifentanil in the body. And then metabolized by your metabolized plasma cholinesterase levels. So no need of dose adjustments whether in your hepatic or renal dysfunction patients. So mostly useful if you want to do your frequent neurological monitoring. Coming to another drug, tramadol, which acts as an agent. Okay, it inhibits the uptake of serotonin and noradrenaline with presynaptic stimulation of serotonin release. It's used in moderate to severe pain. Doses can go up to 100 mg every 6 to 8 hourly, and maximum you can go up to 600 mg per day with tramadol. But all these opioids, they come with a common side effects. All of us know that sacrum is the code to remember those side effects. It might be sedation, analgesia, respiratory depression, constipation, confusion, respiratory depression, and abstinence syndrome. So you have different receptors that correlate with your different side effects of these opioids. But keep this thing in mind when if you're using an opioid infusion drugs. Coming to non-opioid analgesia, we have ketorolac, ibugesic, or ibuprofen, or acetaminophen. So out of all these things, acetaminophen and ibuprofen are most commonly used. Acetaminophen, the dose being 1 gram every 6th hourly, can go up to 4 grams per day at the maximum dose. Coming to ibuprofen, it is 400 to 800 mg 6th hourly, and ketorolac 30 mg IV or IM every 6th hourly. But coming to ketorolac, you need to decrease the dose by 50% in geriatric patients. So all of them will have the most similar actions, but only thing acetaminophen does not have any anti-inflammatory effects. So side effects and complications are more expected with ketorolac, and ibuprofen and acetaminophen are reasonably safer drugs. Coming to benzodiazepines, these are anxiolytic, amnestic, anticonvulsant, hypnotic, minimum muscle relaxation. They act through GABA receptors and they have a higher volume of distribution and slow clearance from the body, minimal minimal CVS and respiratory depressant effects. So what are the various opioids available? We have midazolam, we have lorazepam, and we have diazepam. So loading dose, I think you have to remember these dose. Midazolam can be used as an infusion dose, 0.0 to 0.1 mg per kg per hour. Of all these, the short acting being midazolam 1 to 5 minutes, lorazepam is the onset of action is around 5 to 20 minutes. The side effects profile, when it comes to side effect profile, the side effect profile is minimal for midazolam and then lorazepam compared to diazepam. Respiratory depressant effect, every drug has the respiratory depression. Analgesia, nothing. I mean, no drug of this group does not have any analgesic side effects. Coming to amnesia, midazolam has got a potent amnestic effects, and midazolam has also got an active metabolites here. There are higher chance of hypertension with midazolam and lorazepam. So these things should be kept in mind while you're starting your infusion. Coming to propofol, it's a GABA-mediated anti-drug. Bolus dose is not advised when it comes to propofol. So infusion is generally practiced. The maximum dose you can go is 4 mg per kg per hour. It's a rapid onset drug, the action comes in 1 to 2 minutes of time, and it's a short acting. But the only problem with propofol is increased levels of triglycerides because it's an oil-based drug. There is increased chance of triglycerides and cholesterol levels and chances of PRIS syndrome, propofol infusion syndrome, which is generally seen in neonates and pediatrics especially. So what is meant by PRIS syndrome? If you are going to use the propofol more than 4 milligrams per kg per day for more than 2 days, then there is a chances of propofol reinfusion syndrome, wherein the patient will have bradycardia, cardiomyopathies, myopathies with rhabdomyolysis. The patient's ABG status will show metabolic acidosis, and the potassium levels will shoot up when the patient is on PRIS syndrome. There is a higher chance of renal failure. Sometimes you need to go for dialysis also. Treatment is simply stopping the drug, and if at all, if it is only supportive care. Coming to ketamine, ketamine is an NMDA receptor antagonist. It prevents your nitric oxide synthase release from your blood vessels, and it's both sedative and analgesics. But the only problem with ketamine raises all your pressures. So it's highly sympathetic drug which raises your blood pressure, heart rate, intracranial pressures. It raises your pulse and everything. So and it also causes bronchodilation. So it should be always used in conjunction with narcotic agents, which can be given an infusion dose of 5 to 30 micrograms per kg per minute. Okay. So what are the various other drugs which we generally use? Okay, we have etomidate, which produces hypnosis. Barbiturates like thiopentone can be used if you want. Sometimes the patient will have refractory seizures. You can use barbiturate coma by using thiopentone or pentatol. You have volatile agents, the new generation drugs that are coming in by using an anaconda device. It was displayed here. It's a simple device wherein you can give infusion of your isoflurane or desflurane to the red line, which was shown here. And that infusion is converted into vaporized form, which can be delivered directly into the lung. So it's a less side effect profile drug wherein you are giving only through inhalational mode. So anaconda device can be tried, and haloperidol. Sometimes all your drugs will not going to work on your patient because of your chronic usage or tachyphylaxis. So in those special situations, you can try atypical antipsychotics like haloperidol or quetiapine. Sometimes haloperidol is a dopamine antagonist used in delirium, and any route can be combined with a benzodiazepine for a rapid action. Even quetiapine can also be used for this particular set of patients. And new generation drugs called as alpha 2 agonists are there. So these are centrally acting alpha 2 agonists, clonidine and dexmedetomidine. Coming to the selectivity, the alpha 2 activity is maximum for dexmedetomidine coming compared to alpha 1. Even the half-life of dexmed is also very less. So it can be used as IV. Coming to clonidine, it is less alpha 2 selective, but the advantage is it can be given oral, IV, and even subcutaneous also. So it can be used as an antihypertensive. Most of our CKD patients will be on a clonidine oral tablets. Okay, coming to dexmedetomidine, it's only IV formulation is available. It's both analgesic and sedative. The problem with both of these drugs is hypotension and bradycardia. So if the patient develops a new onset of bradycardia or a new onset of ST depression, you should be very careful by using when you're using alpha 2 agonists. And coming to our actual topic, what are our considerations? So what is your problem when you're going to use the sedative and analgesic drugs, especially in ECMO? So the things you need to remember. So what is my consideration series? The lipophilicity of the drug, the protein binding, the volume of distribution, vasodilated state, tachyphylaxis, sepsis, combination of drug or drug interactions, decreased blood flow to the organs because of ECMO, circuit components, multi-organ involvement, and altered blood flow. So all these factors are going to decide about my sedation dosage or the drug dosages, especially in case of ECMO. Let us go and see each factor individually. Lipophilicity. So drugs that are more lipophilic, okay, which is measured by your octanol water partition coefficient. More your octanol water partition coefficient, more the drug is lipophilic. So more the drug is lipophilic, the more the drug will get sequestered in the circuit, because the oxygenator is a highly lipophilic substance wherein it attracts all the lipophilic drugs. So for example, if you see, Hyman et al. Has conducted a study wherein they mentioned that fentanyl infusion, okay, if you start a patient on fentanyl infusion initially, within 24 hours, 97% of the whole fentanyl gets sequestered in the circuit. Also midazolam, it is because both of them are highly lipophilic drugs. But compared to morphine, it is less lipophilic, so it's not going to get absorbed in the circuit even after 24 hours. Okay. So in another study, they observed that fentanyl concentration remains stable only for 3 hours. Okay. And at 24 hours, it's practically undetectable. So by using fentanyl infusions more than 24 hours, so you ultimately land up in tachyphylaxis and constantly increasing the dosage of fentanyl for the desired effect. Okay, see this small graphs here. If you see for morphine, the lighter graph and the darker graph. Okay, the lighter graph is the control, the darker one is in the circuit. The midazolam and fentanyl, practically after 24 hours, the drug concentration reached to near zero. But when it comes to morphine, the drug concentration is stably maintaining at the same level, even without the with or without the circuit. And coming to protein binding now, again the same physiology here. More the protein binding of the drug, more the drug gets sequestered in the circuit. And if the drug is both lipophilic and protein binding, there will be significant absorption. Example is your propofol. It is highly lipophilic drug and highly protein bound drug. So what happens immediately once you start infusion, within no time of 24 to 48 hours, all the drug will be sequestered in the circuit. So what is the problem? And this is the problem here. What's the solution for this? So drugs which are more lipophilic and drugs which are more protein bound, we need to increase the higher initial dosages with a higher daily dosages. Okay. So our target is to reach the particular saturation of the receptors. Okay, that's the main target here. The example being fentanyl, midazolam, propofol, etc. So all these drugs will require higher initial loading doses with higher daily doses. Volume of distribution. So generally, once the patient is on ECMO, your whole circuit will be around 700 to 800 ml of priming volume. So your volume of distribution increases significantly once the patient is on ECMO. So once it increases, more drug dilutions get happen. So drugs needs to be administered in higher bolus dosages and maintenance dosages too. And again, the volume of distribution is affected by your protein binding. And once the patient is on ECMO, because of the extracorporeal circuit, there is a frequent loss of albumin. So once there is frequent loss of albumin, your protein binding of the drug will come down, your free drug will increase. Okay, that's what happens. And generally, it's more important when it comes to neonates and pediatrics rather than the adults. And again, the vasodilated state. So once the patient is on ECMO, generally the patient will be in an end stage or a near terminal stages. So there will be a chance of multifocal sepsis and shock by the time you're initiating. So already the patient is in a vasodilated state with a background of again a hemodilution. So there might be an exaggerated response of opioids when the patient is on vasodilated states, and even your antihypertensives also. So coming to another factor, which is decreased blood flow to organs, which generally happens in a VA ECMO. So what happens once the patient goes on to the VA ECMO? there will be decreased blood flow to the lungs. So once there is a decreased blood flow to the lungs, what happens? Drugs that are drugs that have high first pass metabolism, like drugs that get metabolized through lungs, like inhalational opioids, inhalation anesthetics and opioids. No, so what happens? They'll be accumulating in your body. So they'll have an exaggerated response in those particular situations. And renally eliminated drugs, yes. And if there is hepatic or renal problems, drugs which are having renal elimination or hepatic elimination should be carefully monitored before administrating. Circuit components. So you might be wondering what's the circuit component relation with your drug dosages. So if the circuit, the most 80% of the circuit is made by your polyvinyl chloride, it actively binds to the lipophilic substances. So it acts as a reservoir for all your lipophilic drugs. So it binds the drugs and then releases later when the concentration of the drug changes. Okay. So there's higher chances of drug sequestration when especially lipophilic substances with the PVC circuit. More the length of the circuit, again, the more the chance of sequestrations. The roller pumps and centrifugal pumps. Roller pumps, if you're using a cardiopulmonary bypass, roller pumps will be more tend for more sequestration of drugs compared to your centrifugal pumps in the ECMO. Coming to priming solution, till now there are no studies that shows any significant change in drug concentrations based upon the type of priming solution, whether it's blood or whether it might be any crystalloid solutions. So this is a simple diagram which shows all the factors that were completely involved here. So let's see one by one. If there is a hemodilution, what happens to your drugs? There will be increased volume of distribution, decreased clearance of the drugs. You need to increase your loading dose. Along with the loading dose, you should increase your frequency. So what are the various drugs here? The same hydrophilic drugs, highly protein bound drugs are the drugs here. Circuit-related factors, as I said, drug sequestration happens, drug inactivation happens with increased volume of distribution. So you need to increase the loading dose again here and then increase the frequency of dosage. When it comes to patient factors, especially if the patient is in sepsis, there will be again increased volume of distribution and increased clearance. So again, here also you should increase the loading dose, especially when it comes to your beta-lactam antibiotics and glycopeptides. When it comes to organ failure, it is a specific drug. Drug that is especially eliminated through particular organ should be decreased. That's a take-home message from the organ failures. Drug factors, as I said, hydrophilic drugs, you need to increase the loading dose. You should maintain the frequency. You don't need to increase the frequency of hydrophilic drugs like beta-lactams and aminoglycosides. But lipophilic drugs, so increase the loading dose, increase the frequency, especially fluoroquinolones, macrolides, and propofol. All lipophilic drugs and all protein-bound drugs, you need to increase the loading dose and frequency. So these are the various factors when it comes to patient, when it comes to circuit, and when it comes to drug-related factors that is going to affect the concentration of your sedatives or analgesics in ECMO especially. So different studies have shown the different dosing recommendations when it comes to midazolam. See the octanol water partition coefficient here, 3.9, and it's highly protein bound. So you need to give higher initial dosage with higher daily dose. Dexmed, almost the same as midazolam. When it comes to fentanyl, high coefficient, that means highly lipophilic and a highly protein bound. Again, significant circuit drug sequestration happens with fentanyl here. So once, if you're using it for a short-term analgesia, is fine. If you're using it for a long-term analgesia, try to go with other alternatives other than fentanyl. Morphine, yes, less lipophilic drug, less protein bound drug. It's only minimally sequestered in the circuit. So you can go with a higher initial dose, but normal dosage on daily basis. Coming to propofol, yes, it's again highly lipophilic, highly protein bound, significant drug sequestrations. So data is lacking, but as per our protein discussions prior, you need to increase the initial loading doses followed by the frequency of the dosages also. So coming to take home points, I like to conclude it here. Every patient is different, but the targets remains the same. So no need to have the same drug, have the same target. So every pain does not need medication. You need to understand why the pain is coming from. Sometimes your non-pharmacological therapy is going to help him much better than your pharmacological therapies. And every patient does not settle down with sedation. Sometimes, in spite of giving you so many drugs, patient is not going to settle down. Don't forget your muscle relaxants in the armamentarium. So if you have muscle relaxants, sometimes you need to paralyze him. And every drug is different. You need to understand the pharmacokinetics and pharmacodynamics of each and every drug and how it is going to affect your particular patient, especially when it comes to ECMO, you need to understand that. So after understanding itself, you have to administer the drug for the patient. And every agitation, as I'm quoting earlier, is not because of pain. Sometimes the agitation might be because of a simple reasons. You need to address that particular reasons. So always protocol-based approach saves you. and need further studies like ECMO PK studies, ASAP studies to understand the pharmacokinetics of different drugs here. So to do a equal justice, you need to know everything. So how to support each and particular patient. Every patient is different. If you want to give equal justice for all of the patients, you need to support every patient according to their clinical status, right? Thank you so much. So any doubts, I'm